Now I would like to invite our next presenter, Dr. Sana Qasim, resident Tier 4 from ENT Unit 2. Thank you.
Assalamu alaikum. My name is Dr. Sana Qasim. I am resident of ENT Unit 2 from Civil Hospital, Karachi. 70-year-old male, labor by occupation with no known comorbids presented to ENT OPD with complaint of change of voice for the last 3 months, difficulty in swallowing for the last 3 months, and difficulty in breathing for the last 2 months. Change of voice was gradual in onset and progressively increased. Initially it was intermittent but later on present throughout the day. No aggravating and relieving factor, noisy breathing during deep breaths and on lying down. There was difficulty in breathing during walk which relieved after taking rest. There was difficulty in swallowing for solid only. There was no history of addiction. General physical examination was unremarkable. Oral cavity examination was unremarkable. Neck examination. On inspection, there was change of voice and stridor was noticed during deep breaths. No swelling in the neck was visible. Laryngeal capital was intact. Trachea was centrally placed. Neck nodes were not palpable. Next. Apodial findings. Apodial was done. We showed a well-circumscribed submucosal mass involving the valvuculi, piriform fossa and posterior pharyngeal wall on the left side. Overlying mucosa was intact. Laryngeal inlet was partially obscured by the mass and was shifted towards the right side. Vocal cords mobility could not be assessed as the mass was obscuring the view. Next. Investigation. Baseline investigation. Series carried contrast was done. We showed a heterogeneously enhancing mass in the region of hypopharynx centered over the region of piriform fossa, causing anteriorly narrowing of the lumen. What would be your surgical planning?
What should have been done for postgraduate trainees? DL biopsy, very good.
Direct laryngoscopy and biopsy was done. Tracheostomy was done before the procedure. On DL, there was a well-defined submucosal sessile mass identified in the region of piriform fossa extending into the posterior pharyngeal wall and valvuculi with overlying intact mucosa. It was firm in consistency. Multiple chunks of biopsy were taken from the growth. Profuse bleeding was encountered during the procedure. Bleeding was secured by throat packing and patient was shifted to surgical ICU. Next. On the next day, an external approach was planned and tumor was removed in toto while lateral pharyngotomy approach but found tightly adherent to underlying pharyngeal wall. Next. Follow-up. Post-operative period remained uneventful. Tracheostomy tube was removed at the 5th post-operative day. Patient voice became normal. NG tube was removed successfully at the 10th post-operative day. Next. What is your diagnosis?
Presented to our ward with history of dysphagia, difficulty in swallowing and change of voice. He was also having difficulty in breathing. So we planned to perform direct laryngoscopy under general anesthesia. While we were performing that, the very massive bleeding started. So we had to shift the patient to surgical ICU, and in the meantime we decided to operate the patient, because the bleeding was more and the patient was in the surgical ICU. So we operated the patient, and after operating the patient, now the question is, what would be your probable diagnosis in this patient? For postgraduates first. Who would like to answer? CA hypopharynx. Okay. But normally the CA hypopharynx does not bleed that much. The patient bled a lot. It could be angioma, very good. Any other? Any other, please? Okay.
Next. Following differential diagnoses were made: vascular tumor, hemangioma, lymphangioma, benign mesenchymal tumor, lipoma, schwannoma, or neurofibroma. spindle cell tumor, leiomyoma, myofibroma, or malignant cell mesenchymal tumor, leiomyosarcoma. Next. Histopathology came out angioleiomyoma. So immunohistostains were performed showing anti-smooth muscle antibody was found positive while CD34, S100 and Despin were found negative. Angioleiomyoma. It is extremely rare tumor of hypopharynx with only one case reported in the literature. Angioleiomyoma is a benign, slow-growing, soft tissue tumor that originates from vascular smooth muscle. Next. More often, it is located in extremities, lower 59%, upper 15%, uterus and gastrointestinal tract. Head and neck localization is very rare, only in 13.1% of the cases. The most frequent sites are ear, lip, nose and neck. The laryngeal localization is extremely rare. Next. Histologically, it is divided into three types: solid and capillary type, venous type and cavernous type. Next. The most common presentation of angioleiomyoma is pain with or without tenderness. However, angioleiomas of head and neck region usually present as painless masses. It is difficult to diagnose angioleiomyoma clinically and radiologically. Next. The histological and immunohistochemistry examination is the only available instrument to obtain a correct diagnosis. Surgical excision is the treatment of choice. The chances of recurrence in these types of tumor is rare. Next. These are my references. Next. This is a video.
शाबाश। अब आपकी तबीयत कैसी है? माशाल्लाह।
बिल्कुल।
आप खुश हैं? अपने गांव वापस जाना चाहते हैं?
सब परेशान
अच्छा चलिए। अल्लाह का शुक्र अदा करें।
Morning में आया था. CT scan report was showing that there is a vascular enhancing mass on contrast. But वो vessels सर when DL inserted उसके बाद ही उसने bleeding start कर दी. Then हमने उसमें पैक रखा, try to stop the bleeding. Then patient surgical ICU shift. ट्रैकी तो हमने पहले ही कर ली थी because vocal cord was not visualized और उसमें intubation was not possible. तो उसकी वजह से हमने पहले ही प्री ऑपरेटिव ट्रेकेस्टमी कर ली थी इलेक्टिव.
You the second case, so you should report it. You remember Zeba or Tariq Zaid, we removed a case of angioleiomyoma in a child who was on bed number 18. And it was arising from the gingiva. Right? Yeah.
This case would be the second.
Yeah, you must report it. You must report. Exactly.
We do not report mostly.
It could have been even the chemodectomas.
We were thinking of
Carotid body tumor. Sometimes, even sometimes the paraglottic lesion, they are present like this. They are mucosally covered. You keep on taking the biopsies, and the biopsy turned out to be negative. And this is a false negative. Even the CA thyroid, sometimes हमेशा हर चीज में नहीं थे, ब्लीडिंग नहीं थे.
No history of bleeding in the past.
Muscular lesion, और यहाँ there was no evidence of any vessel involvement in cases in CT report. That's why they performed the.
Facility हम आपको ऑफर कर सकते हैं. At SIUT, we have the facility of CT angiography. This is an excellent, investigation.
Yes.
So if you have a
MR angiography and CT angiography, both.
nice.
Yeah. Okay, well done.
Thank you, Dr. Sana Qasim, for presenting such a rare case. I am sure most of us residents didn't even know about such an entity. So a round of applause for that resident.